It's now gone eerily quiet apart from the noise of these very, very noisy fans. So thank you very much for your patience with them during the afternoon, and welcome to our board meeting. We've got a new face round the table, and we've got people standing in for other colleagues, and I'm never any idea who knows whom. So we'll do a quick round of introductions if that's okay. I'm Mike Thorne, Chair of the Mid and South Essex Integrated Care Board. Tom.
Thank you, Mike. Tom Abel, Chief Executive of the Integrated Care Board.
Barry Frosty, Chief Digital and Information Officer for the Integrated Care Board.
Matt Sweetin, Medical Director for the Integrated Care Board.
Giles Thorpe, Chief Nurse for the Integrated Care Board.
Dr. Anna Davey, Primary Care Partner Member.
Good afternoon. I think I'm the new face. I'm Rob Percy. I'm the Exec Director for Adults and Health at Thurrock Borough Council.
And you're very welcome.
Thanks. Afternoon. I'm Mark Harvin, the Exec Director for Adults Communities for Southend City Council.
Good afternoon. Simon Griffiths, Alliance Director for Adult Social Care, Essex County Council for Buzzard and Brentwood. I'm stepping in for Peter Fairley today.
I'm Dan Doherty. I'm the Alliance Director for Mid Essex.
Becky Jarvis, Alliance Director for South East Essex.
Pam Green, Alliance Director, Buzzard and Brentwood. Welcome to Buzzard. Thank you all for coming. And Executive Director for Primary Care.
Good afternoon, Neha Brown. I am a non-executive member for the ICB.
Hello, Shahina Pa'ardan, Associate Non-Executive Member for the ICB.
Hello, Jeffrey Olsen, Associate Non-Executive Member on the ICB.
Good afternoon, Joe Fielder, Non-Executive Member.
Good afternoon, George Wood, Non-Executive Member.
Good afternoon, Jo Cripps. I'm the Director of System Recovery.
Hi, and I'm Kathy Bonney, Interim Chief People Officer.
Hello, I'm Claire Hankey, Director of Communications and Partnerships for the ICB.
Emily Huff, Exec Director of Strategy and Corporate Services for the ICB.
And I'm Ashley King, Director of Finance and Estates for the ICB, deputising for Jen Pearson, Chief Finance Officer.
I noticed Jen told him to sit next to me to keep an eye on me, to avoid the spending of money at all costs. Pam, it is nice to be here, and it's just stunning how well used this facility is. Quite incredible, and in fact it struck terror into my heart in case I was going to be required to don a leotard and do something down in one of those halls. Very scary, but just
still time, Mike.
Still time. But fabulous. Careful what you wish for, but it's still fantastic to see so many people engaged in physical activity here. So welcome to everybody. I'm not going to go through our list of apologies. Anyone got any thing they want to add to the register of interests in relation to the matters on the agenda? Not going to move on. We've had some questions from the public. There were two questions from two members of the public which were of a personal nature and also not relating to an agenda item today. They will receive personal responses from our patient experience team as is appropriate. Peter Blackman has asked a question, noted the importance of communications and engagement strategy refresh, and that there did not seem to be any reference in the strategy highlighting the need for alliances to be supported along with PCNs and INTs to engage effectively with local and common interest communities. He says, trusted community voices are key to your effective communication and engagement. What will you do for this? And will you accept the support of a consultative group to bring added expertise to help your communications engagement work? And I think Claire Hankey is going to respond to that. Claire.
Thank you, Mike. And I know Peter couldn't actually attend today, but he is going to be watching online. So hello, Peter, if you can see me. Just wanted to thank you for your question and your supportive comments regarding the refresh of the communications and engagement strategy. The strategy, I feel, does emphasise the importance of alliances and partnership networks, including primary care networks and integrated neighbourhood teams in effectively engaging our local communities. This approach is central to part of our refresh strategy, which aims to build a more collaborative relationship with our trusted community voices. To strengthen these alliances, we will continue to support our partners with the tailored resources, training and shared channels, ensuring they have the needs and ability to communicate and engage effectively. To further support this in recent years, we have established a readers panel, which has been invaluable in refining our communications approach and content. The group provides direct feedback on proposed materials, allowing us to tailor messages that align with the needs and preferences of the communities we serve. For campaigns, we utilise the OASIS model, for example, which enables us to conduct targeted research and audience analysis ahead of individual campaign planning. I agree that by gathering community-specific insights, we can craft communication assets that are, sorry, I need to turn the page, that are not only accurate and accessible, but also meaningful for each target audience, thus avoiding a one-size-fits-all approach where possible. We are committed to enhancing this model, ensuring communications are informed by diverse voices and reflect the varied needs across our service areas, as demonstrated by our recent work on developing primary care access communications. Thank you once again for your supportive feedback.
Thank you. Chris Gasper asked first of all for assistance to access our live stream, which is of course located on our website, and received that assistance, and I hope therefore Chris is able to join us remotely, and also whether or not we were considering live streaming the ICP meetings, and that is currently being considered. So that brings us to the end of those questions. Come now to the approval of minutes of the last meeting, and Rob, silence is 1000% endorsement and approval of what's there. So if people happy with the minutes, everyone happy? Okay, thank you very much. We then come on to the action log, and there's 2 items which are complete and 1 which is ongoing, and all that is sort of moving along. Are there any other matters arising that are not on the agenda that any member of the board wanted to raise at the moment? If not, thank you very much indeed. So we now come on to our first substantive item to today, which is the Lampard inquiry update. And I think, Matt, are you going to speak to this?
Thanks, Mike. We are going to just give an update on the Lampard. You've taken the paper as read. I think it is worth me reading out again what we read out as a group of ICBs at the inquiry publicly, if that's okay. And then I will hand over to Mike Thompson, director who's leading on Lampard, to update and answer any questions. Once again, as an ICB, I and we would like to express our deepest sympathy for all those who have lost loved ones and those who have been and remain affected by the matters that this inquiry is examining. It is hoped that the inquiry's robust investigation will provide the answers that many have been waiting for. And the ICBs would like to recognise and the courage of those engaging with the process despite their loss and suffering. I'll hand over to Mike to introduce you to Mike, and then we'll take questions.
Thanks, Matt. So I'm Mike Thompson, and I'm supporting Matt on the response to the inquiry. I hope the paper was self-explanatory. It effectively gives you an update in 3 key areas of the inquiry. One is the opening hearings and statements, from which you've just heard from Matt. The second part is describing what's called the Rule 9 request that we did receive as ICBs in the summer, and our response to that. We expect to receive more as the inquiry goes along. And the third part just describes the project arrangements that we are establishing and have been establishing with our other 2 ICB colleagues to create a sort of project infrastructure to be able to respond to the inquiry. And then the opening statement, which Matt just read from, is an appendix to the paper. So it's an update for information at this stage. It's early days in the inquiry. The next hearings are at the end of this month, at the end of November. They will continue the commemorative approach to hearing from affected families, and then more formal hearings will take place in April next year, at which point we may have had more requests from the inquiry to provide information. So we've geared up the project, we've responded so far to the inquiry, we've made our opening statements, and our King's Counsel went and read that to the inquiry. So I think we're in a positive position, and we're working well with our other ICB colleagues. What we're expected of the inquiry to be determined, but we're as prepared as we can be at this moment in time. Happy to take any questions.
Thank you. It's just keeping board members up to date with the progress of the inquiry at this stage. Thank you very much. Thank you, Mike. Moving on then to the next item, which is equality and diversity and inclusion, high impact actions. Kathy.
Thank you, Mike. So a couple of things just to say that I'm minded now of two things as we look at this data together, and that both of those are coming from the session we've just had as a board development session around our approach to equality, diversity and inclusion in the ICB and our system as a whole. And I think the two messages I took from that, and I hope they're helpful for the board, is that we should avoid the temptation to try and look better than we are in relation to the data that we're looking at, and also that we need to use the data to commit to improve and not just look at the data as data. So those were two key messages I took from that. So the EQ&I High Impact Action report is a first report following a commitment by this board to look at the 6 high impact actions, which are a national directive for us. And interestingly for the board, were actually worked on by Roger Klein, who we've just spent some time in the company of. And it's about the board's commitment to monitor our progress against them. So at the moment, this is an incomplete data set, but I wanted to bring it to the board to show the board we had made progress in trying to collect data on our system in terms of where we are, in terms of national benchmarking, and against each other, actually, and where we might learn good practice from each other in the system. We are also looking at including in this data set for 25-26, it's an annual snapshot report, data from North East London Foundation Trust staff who work for us in this patch, of which there are approximately 1,000, not the whole of North East London Foundation Trust. We're looking to build the data from Provide, our community provider. We're also looking to include Essex County Council, and I'd welcome data from any of our other partners around the table for that 25-26 submission. This report was created by Nunzio Toscano, who's in my People Directorate. If there are really detailed data questions, I may have to go back and ask him because he is my guru on this and I'm not. So thank you, Mike.
Yeah, thanks. So could I ask, is the issue that Provide are not collecting the data, they're not collecting it in the format we need it, or that there are issues about sharing the data with us? And Lucy couldn't be here with us today, and there wasn't anyone who could stand in for her. So if she was here, I'd ask her the question directly.
No, I can assure the board that there isn't an issue with them providing data. They are working really closely with us. They just don't ask the same questions as us at the moment, but they plan to. So I think there'll be a coming together over the next year or so.
That's good to hear. Neha?
Thanks, Kathy. Just in spirit of what we had in the session with Roger around in EDI and so on, there is concern at times that the data that is received from our providers, from trusts and so on, might be cleansed, or it might not actually, give the whole picture, if you like. Now, obviously, we go on trust and that what we have in front of us, as you said, there's no issues with it. But what measures are in place to ensure that we're getting the full context, full picture, non-cleansed data as it would be on ground, and therefore be able to get the right conclusions from it?
Thank you, Neha. So the data is taken from existing sources which are regionally and nationally recognised. So it comes through Model Hospital, and most of their data comes through Model Hospital actually, and through other data sources. We have just entered into a data sharing agreement with MSEFT and ePut, where they will give us access to source data. So I'm confident that at the moment we're getting the data that's nationally recognised. It's not sanitised for our use, and in the future we'll actually have access to much more data with our data sharing agreement, which has just been signed by both parties.
Thank you, Shahina, and then Jeffrey.
Thanks, Kathy. With these data, do we have an idea about the response rates from the different providers? And what sort of response rates have we got to actually make? put into these data? Because we've only got percentages here.
So typically MSCFT and EPUT, in terms of the questions that are taken from the staff survey, if that's what you're asking me particularly, then they operate around 30% return at the moment. We were just talking about this last week. So we've got a commitment through the engagement group that we're running as a system to improve that figure. That's one of their objectives. So it's a more realistic response. As I say, all the other data comes from model hospitals, so it's not staff comment, if that makes sense. It's actually
because it's usually people who don't have any complaints or don't have any problems don't respond, so it might actually have a different performance rate.
Thank you.
Thank you, Jeffrey.
Thank you, Kathy. Just two comments, I suppose. The first one is good to see progress being made, good to see the data coming through. And I suppose it's the template of this report that you see the data, and then for me, it begs the question, so what? Which is not captured here. I know it may well be captured in the EDI strategy, which comes later. But one thing that struck me is, which is perhaps not surprising, around one, the biggest barrier to career progression is ethnicity, for example. And the biggest discrimination is around ethnic background. So it kind of, across all three NHS organizations. So it kind of begs the question, which we want to then answer, what are we doing about that? That's the first bit. The second bit is that there's a subgroup called ICS, People's Board, a subgroup of the People's Board. I think it's some sort of EDI subgroup of sorts. Can you just say a bit more about how that is constituted and to what extent? Because I think the governance around all of this is important, and to what extent they can effect change. Thank you.
So Kathy and Joe might want to comment too.
Did you want to go first, Joe?
Happy for you to.
Okay, I'll go first then. So,
so speak further into the microphones because it's not coming through.
Is that better?
Yep.
Okay, fine. So yes, so in terms of the architecture around equality, diversity, inclusion, both for the system and for us as an ICB, is contained in the strategy, which is coming next. But suffice to say that what we've created in MSC system is three subgroups that report directly into the People Board with 6 weekly highlight reports. One is looking at the capacity and expansion programme around the long-term workforce plan, which I mentioned in the session with Kit Connick earlier. The second one is looking at colleague engagement and retention. And we'll look at lots of the areas that you just mentioned around staff survey, et cetera, and then the third group is chaired by Lorraine Hammond, who's the SRO for our system, and EPUT, Director of Employee Engagement, I think it is. Apologies, Lorraine. So that group is a formal group, subgroup of the board, and it actually reports through a formal highlight report so we can track progress. It is responsible for these 6 high impact actions. They are part of its delivery. And so that's currently how the governance works. Internally, we've got our inclusion and belonging group, which Giles chairs and I'm deputy chair for, which again looked at this data for the ICB only, because I've got a separate data set for that. So that's currently how we're operating. But Joe.
Yeah, I think it's a really helpful observation from Jeffrey, because my sense of things at the moment is we've got inadvertently perhaps a degree of siloed views on this. So we've got the high impact actions reporting into People Board, which is helpful because it means People Board at a strategic level with partners is looking at, are we doing enough there? But then when we see data coming through, which as Jeffrey says is really helpful, we need to ensure that we find a way to connect and align all of the work for maximum impact. And I'm not sure we're quite that mature or refined yet, if I can be honest, Chair, but I think we can see more clearly what needs to be done and how we need to better connect things. I think the strategy that comes later is a very, very good paper, but it does show some missing links, I think, still. I'll leave it there. Thanks.
Thanks, Joe. Tom?
Thank you, Mike. So I think it might build a bit on Joe's point. I think there is a action following this discussion in terms of how do we do that join up. And I think we've said that we need to keep this a kind of regularly and routinely reporting through to this board. And I think maybe, Joe, we can use the people committee as a mechanism to provide assurance through to the board that these actions are being delivered. And where we've got measures, obviously things like the staff survey only happen annually, but where we have got things that we can look at more frequently, we're doing that. So I think, Mike, if you're happy, we can take an action to just work that through and make sure we're seeing it regularly at this board meeting.
Yep. Nods around the table. Becky.
Thank you. And perhaps builds on that. I'm really struck, Kathy. I mean, I think this is really helpful, and obviously it gives us the data to think about how we move on, and it might be in the strategy. But I'm particularly struck by the high impact 5, where one of our providers are on red, and in particular reference that around international staff being more likely to experience bullying, harassment. And I think that really builds on the conversation we just had. So what I'm really keen to know is how that join up for some of those issues, because actually we could look at how we recruit international staff as a system, not just organisations. And if other organisations are further on, that's the benefit of that learning.
Thank you. Okay. Well, I mean, this is all coming together with our earlier board seminar, part of our training, really, and these papers today. This is demonstrating a focus and a commitment that then needs to be matched with the executive action that Tom is talking about there, and we've got a monitoring mechanism developing now here as well. So I'm going to move on then, if that's okay, to the Equality, Diversity and Inclusion Strategy. And I, not least of anybody, have to say thank you to everybody involved in putting this together, Kathy, because I think my copy of it was scribbled all over the one I passed on to you, wasn't it? And actually, all the various comments have been responded to in a absolutely supportive and helpful way in the spirit the comments were made. So thank you very much indeed for that. The board will still make up its own mind whether it wants to support the strategy or not, but I certainly felt that my comments and concerns were responded to, so thank you. And over to you, Kathy. And Emily, you're maybe commenting as well.
Yes, thank you, Mike. So just to say a big thank you to Nick Adams, who's sitting to my right, who played an absolutely blinding part in pulling this together. And whilst she had contributions from me and from people in Emily's team, she did do the work. And so I wanted to acknowledge that. And I think it's shaped up well in terms of an actual strategy. So this strategy covers off 2 of our duties, really, as an ICB. One is in relation to our staff, which is the conversation we've just been having, and it outlines more data in relation to our staff than the high impact actions, because obviously they're very specific. And it also talks about some of the things we're doing, some of which were mentioned earlier around trying to develop and grow our staff networks, thinking about better uptake with our staff survey, which we're achieving, and other things that are in there. But I'm not going to say any more about that. I'll just pause there in case anybody's got any questions on that part of the strategy, and then I'll hand over to Emily to talk about the commissioning and health inequalities section.
So any comments on the bit that Kathy's, I mean, in a sense, this has been quite well aired because we did have a seminar on it during the construction phase. So lack of discussion is because everybody, like me, I was able to put their oar into getting it to a better place then. So thank you. So then on to the other side of it, Emily.
Yeah, thanks, Mike. And I mean, we talk about health inequalities and what we're doing as a system with a reasonable degree of regularity, I think, in terms of what our strategy, our actions and our impact is in regard to how we're looking at how we support addressing the health inequity experienced by the people in our population. That comes through, I hope, in this strategy, which draws on all the other work that we're already doing around health inequalities and highlights our kind of corporate commitments and objectives in this space. And I think it does fit really well with thinking about how we're considering the balance of action we're taking around supporting our staff as well as our patients. Actually, it is well looked after staff are going to deliver good care for our patients. So these two do fit together really well. Happy to take any questions if people have them. But again, my thanks go to Emma Timpson and Sophia Morris, who lead a lot of our work on this, and again, Nick, who's done a lot of the drafting. So yeah, I think it's really positive that we've had so much engagement, not just around this table, but you'll see actually the breadth of engagement that we've had from across our system, our Health Watch colleagues, different teams across the organisation who've really contributed to this so that we get a breadth of insight and experience. The key thing now is that we work to deliver it, and I'm sure that there will be returning papers in the future so that we can keep updating you across both our own workforce and health inequalities, and no doubt collectively as well.
Thank you. Rob, you looked as though you might want to come in. I mean, just scratching your ear can get my attention, but thank you. Jeffrey?
Thank you. I mean, we've seen this before. And oh, sorry. No, I was trying to catch your attention. So. Yeah, so it's really good strategy. Thank you. We've seen it before as well. And thank you, Nick. I think I just had two quick questions, if I may. The first one is on resource allocation, which we say we want to develop it in a sustainable way, not just for the EDI work, but I suppose for the health inequalities as well, and the extent to which, we can try and adhere to that, because it's quite easy sometimes not to, is my point. But also we think, or some people think, or the suggestion that the EDI resourcing, I know it's a very difficult environment financially, but that more could go in that direction, and whether in the short or medium term, Emily, as we plan around EDI work. My second point is, I think I picked up somewhere this anti-racism strategy, for example. Not sure I've seen it, but, can we, or if I've seen, I've forgotten. Can you throw a bit more light? Thank you.
So just on the resourcing question, that's definitely a question for Tom. Okay, I'm not expecting to award money here today, and then I've got Kathy and Emily. I don't know who wants to go first, but Tom, do you want to talk about resourcing?
Well, I think Emily might want to.
Okay.
Yeah, so I was going to comment on the resourcing actually, because I think there's a real balance here where we have some dedicated resource to support how we're driving health inequality and EDI across our system. But actually the critical thing around this and how we resource it is embedding it into everyone's job. Yeah. So actually it's not about having a health inequalities program over to the side. I think one of the things that the system has done really well on that, and we're really talking about how we do it on the people side as well, is embedding the requirements we have to address change so that it's part of everyone's job and everyone's business, therefore recognising how we can maximise the resource that we have. Obviously, we do have a health inequality investment commitment in our ICB, and we continue to support that, and we have a number of workforce kind of financial commitments as well. I'm sure we'd always like to do more, but I think the question to us is, are we maximising the resource we already have, and really working collectively to deliver on these? So I think there is a lot that goes unseen, but not hopefully unrecognised across the system in both areas.
Okay, does that cover both your points? Okay.
Really anti-racist.
Oh yeah.
Okay, thank you. So where you've seen it, Jeffrey, in the paper is as part of the deliverables of the system Equality, Diversity and Inclusion group. It's one of their pillars in there. As far as I'm aware, as yet, we've adopted it in the system, but we haven't implemented the requirements in relation to it. I think that will be the next task for that group. So I'm happy to update the board as you wish.
Great. Shahina?
Thank you for this. I really welcome this. This is a really good strategy. Thank you. I was really pleased to see how we will track progress on our objectives on page 106. What will success look like to you, though? How are we going to track success? Are we looking at data? And if so, are we looking at KPIs?
I think it's got to be a balance actually when it comes to some of these things about quantitative action, some of which we've set out in the table, but also the qualitative insights actually from whether it's the people survey or how we're listening to our communities and people's voices across the system. So I think it's always got to be a balance of that. I believe that we did set out some kind of measures of success against the strategic objectives in the table. I'm just going to see if I can find it across page kind of 90 to 92. So we did say within that what success looks like. So I hope we'll be able to come back across those actions and those specifics in future years to be able to, or months hopefully, not waiting years, to be able to track what we're doing.
Thank you, Barry, and then Rob.
Thanks, Mike. So agree with comments from other colleagues, really helpful paper, and it's been round the conversation a couple of times. Emily, the tables you were just calling out there, so I think it's really helpful to get a separation of the organisation commissioner type of responsibilities and then the measurable points you put in there from us as an ICB employer. I wonder if the next part of the conversation is, through those discussions as a commissioner with our partners around the table, what are the metrics that those partners will then be working to support EDI moving forward? Might be a lower level of detail, but I think that would be really interesting to see and reinforce some of the charts, Kathy, that you've explained in the previous item.
Nod of agreement. Rob?
Yeah, thank you. So my question actually follows that slightly, which is, again, I think it's really interesting. New to Essex, new to the ICB, really good strategy, enjoyed reading it through it. I suppose my question is around raising awareness, because in a way, in this room, we've got the NHS and NHS providers nailed. You've got the three upper tier authorities all represented and on board. There's that wider partnership, including, you know, other providers in social care, the voluntary community sector, who all need to be engaged in this. It's just understanding how we promote the visibility, raise the awareness of the strategy, and also how we encourage the wider partners in the system to take on board the actions and to live this as well.
I'm not sure, Joe, if you want to answer that, but our ambition for our people board is to have that as completely representative across the whole system. So we've just included in our membership representation from the voluntary sector, and we also do have representation from Essex County Council on behalf of the local authority colleagues. We're constantly reflecting on who else we need round the table. With all these things, you know, it's a work in progress, and we are growing. But also, I know that Joe is quite mindful that the group doesn't get so big that it becomes meaningless in terms of what it can deliver. So we're trying to get that balance right. But yes, those representations are now on our people board.
And just to cover the other side of it, in Mid and South Essex, we have a population health improvement board, which both reports on our actions around health and equality here, but also to our integrated care partnership that also has VCSFE partner representation on it and a really broad membership. And our health and equality work goes through that board and into our integrated care partnership as well as coming here. So we have a dual kind of reporting, and a lot of the work on health and equalities is done very much in partnership with your own public health teams, which we're always grateful for.
Thank you. Joe?
Just want to stress really, Chair, in response to Kathy's reply already, I still think there's work to be done in alignment so that we're more consistent in our common thinking and particularly specific actions around this, Robert, you know. So I think it's a maturity issue in there as well. Yeah.
We've tried as we've run along, as just thinking aloud really, but you raise the issue. I mean, the membership here is very tightly constrained by government. We were given very limited choice, and as a community locally we discussed how best, frankly, to spend the seats we were allowed, if I can put it that way, because numbers were constrained by government. And we tried to play in, therefore, other voices that it's important we should hear through the committee structure and things like that, where it isn't constrained by government. So that's been our approach, and we've been cheerful in standing back and saying this isn't working, let's try to a different way. So, you know, as you grow along with us, all contributions gratefully received, really, experience from elsewhere and so on. So I think now I'm starting to be against time. And as everyone said, we've had a lot of engagement with the strategy as a whole. We're asked to approve our equality, diversity and inclusion strategy. And with all the above caveats, including this now needs to happen, otherwise it's just words, please. And we're not here to waste time like that, are we? Are we happy to approve the strategy? Everyone happy? Thank you very much. And again, thanks to all involved in putting this together, and especially Nick, who I didn't mention earlier on, but others sensibly did. Thank you. So we now come on to the winter plan. As you know, the clocks go back and our hospitals get full. And having recently taken a holiday somewhere where they don't do summer or winter time, I now know how to resolve this issue for good, which is to abolish winter and summer time. But seriously, this is where we come under the most pressure across the whole of the health and social care sector, and planning for it is one of the vital things that we do, because we know that we're going to be in extremis as we get across the Christmas period. And this year, of course, we know it started earlier than ever, so it's hardly really a joking matter, other than what I gather is called gallows humour. So Emily, on to you for our winter plan, please.
Thanks, Mike. So what's presented in the papers, which I will take as read, is the approach that we're taking across our collective integrated care system for the strategic and operational management of our 2024-25 winter system. We're thinking about the different levels of how we approach this across strategic planning and coordination, tactical oversight of key areas of challenge, such as discharge, flow and prevention, and then the day-to-day operational management and challenges. This is all being coordinated across the system. We have inputs in here from our primary care colleagues, from the community collaborative, from our acute provider, and collectively across the system, thinking as well about how we utilise our social care partner assets as well. So this is a really collaborative winter plan. We're reflecting on how we support both adults and children. So we've asked for resilient plans around how we support our children's services through winter as well. And we're really making sure that we reflect on national guidance. And as the board will be aware, our system lead for urgent and emergency care, Sam Goldberg, is helping us in this, and then also helping contribute to regional thinking in this space. So I think we are doing well to have a plan, but it is not without risk. And some of that is set out in this paper in terms of where we're at in our bed modelling assumptions for this winter and some of the challenges that we face. There are a number of specific mitigating initiatives to support us really utilising the capacity we have across the system that are set out in the paper. Those are very much collaborative system activities that our primary care team are involved in helping around prevention, our community collaborative in terms of utilising their capacity, and of course MSEFT utilising all of the different types of capacity and staffing that they have. Even if we implement all of that, we will still face pressure in our system. Therefore, these kind of approaches that we have for day-to-day operational management, tactical and strategic kind of weekly check-ins and regular reporting to our executive and to the board are going to be really key to help us manage the balance of operational quality and performance, as well as finance through the system, so that we're aware about the risk that we're facing. We're also really mindful of balancing support for our patients who are already in a healthcare setting, but also those that are in the community. So regular conversations with East of England Ambulance Service and understanding protocols that are coming in around how we ensure they're free to go back to serve the people in the community who might be in need of help. So there's a huge amount in here. My thanks goes to Sam, her team, and all those across the system who are pulling this work together, that weekly group who's providing that sort of tactical oversight, and our strategic command centre who have multiple daily calls to help us manage the risk that I've described.
Thank you. Questions and comments, Joe?
Yeah, I was really heartened by the paper. I think it's an early in the day, very good thought through winter plan with some important new initiatives, and I know a number of those are enacting at Phoenix House as from the beginning of this month. The thing that disquiets me, and it's probably the only thing in the paper, is the lack of a sense of financial implications linked to what you just talked about, Emily, with regards to beds, because I appreciate it's very collaborative and everyone's contributing to bring that 168 beds down to 40, but there must be financial implications if we don't make the mitigation stick. And it would be helpful, I think, for board to understand, you know, how much extra pressure on everyone that might bring. But that was probably my only observation from an otherwise very, very good paper and a good winter plan. Thank you.
Thanks, Joe. I think Tom wants to begin a response to that.
So you're completely right, Joe. So that there is obviously this plan does involve threading the needle, and so there's a huge amount of risk with it in terms of it assumes, well, the best case obviously assumes that everything is delivered to 100% of expectations, and we know that very rarely happens. So we are carrying a level of risk in the system, and clearly the way that would be initially managed is through the well-rehearsed protocols that the hospital have around full capacity protocol and other things like that. But very important that we maintain safety and quality as far as we can as part of those steps. A kind of rough kind of estimate in terms of escalation ward, so 25 to 30 beds is probably £200,000 risk a month. And so if you look at some of these other scenarios, it's a significant financial risk, and it is a conversation that I've had with all of the other chief executives of the NHS organisations over kind of the last month or so. So we're going in very eyes open in terms of the risk that we're currently exposed to, and we will have to just manage against that, unfortunately, in terms of there isn't specific winter funding this year. We know our financial position is not where it needs to be as a system, and so but ultimately, if at the end of the day we're in that position, the safety of the service will have to override the financial considerations.
Very helpful, thank you.
Yes, Anna?
So just a quick question about the bed model. It says we need to use the virtual wards more. Is there a plan to allow GPs to step up into virtual ward beds as part of admission avoidance?
I'm seeing nods from my Alliance colleagues on that.
Would they even like to speak?
Was trying. So yes, there is, and that is already happening, particularly around respiratory. There's been some work in South East, Anna, so we can pick up. I think the area we do need to think about is across all of these areas in the bed model, whether it's SDEC utilisation, whether it's virtual wards, there's an interdependency across the system, and particularly with primary care, particularly with social care. And we have to think about what that step up might look like, but also step down in order to reduce that length of stay. So that's the collaborative work that's ongoing. And I think there's more we could do to build on those relationships.
Pam?
Yeah, and I think the critical infrastructure around that is our transfer of care hubs, where actually the teams between the community and our integrated neighbourhood teams can escalate through and work with social care to ensure that we can put care in at home, being virtual ward, but make sure that we have that admission avoidance through that primary care lens, as opposed to having to go through a hospital bed to access any of that. So that's absolutely the ethos of the transfer of care hubs. The dialogue between community as identifying people is really important.
Just thinking, practically, if I'm visiting a patient at home who has an acute exacerbation of COPD, and an alternative to calling an ambulance might be to put them into a virtual respiratory ward bed.
BCRT.
Yes, but that process we need to be confident in. Yeah.
Yes, your replies to get a thumbs up Neha.
Yeah, just continuing on that in terms of the community resources that we can use, and it's a very live issue that's come around pharmacists, for example, and and how much pressure this and our plans and the downstream might put on some of those community resources, and how is our community feeling within our patches into how they might be thought of in this whole plan more broadly, not of course in the acute sense, but actually developing to acuity sense. Is there any discussion around that? I know it's very live, so we may not even have had thought internally or discussed it internally.
Yeah, so if you're talking about the announcements today around pharmacies taking action akin to our general medical colleagues with collective action, that hasn't been digested as such as yet. But what it is positive to say is that we've got 100% take up of Pharmacy First, and we've got really good engagement with our pharmacy colleagues, and they're supporting us to develop our strategy for the future. Tom spent time with them, engaging them, and actually I think our relationships are very positive in that space. It doesn't nullify the fact that some pharmacies are describing nationally that there is fragility around their funding, but we're keeping very close relationship with them around those sorts of issues.
And presumably we are also supporting them.
Yes.
Yeah.
Emily, and then I'm going to need to start moving us on for time management purposes.
Yeah, just a couple of other things I sort of want to highlight, I guess, that are broader out in the community that really helping with this. So one is our communications campaign through winter, which is helping patients understand how they can access some of those services you were just describing. And then the success of our kind of vaccine roadshow. So we had a brilliant bus that went across that Tom's referenced in his chief exec report as well, encouraging our population to vaccinate themselves, to protect themselves and their families through winter is a really critical part of this. And I think that's another area where we've really thought about the health inequalities, how we can provide our services to people who don't find them easy to access, take them to them. So I think that's another really, and that's been hugely supported by a broader primary care team and pharmacists. So that's another success for our system, I think.
Okay, thank you very much. We've got to approve our winter plan, and I'm kind of hearing that we do. It seems to me, I mean, the success of this, as in every year, depends on the quality of our ability to work as partners across the health and social care system, doesn't it? And it hangs on the discretionary effort of so many people pulling all that together. And we will, yet again, I'm sure, be very grateful for that, because that's what it demands of us. So thank you, Emily, and everyone involved in everyone you've mentioned in dispatches, so to speak, putting that together. So now we come on to communications and engagement strategy, and Claire, you're going to speak to this.
Yeah, thank you, Mike. So I'm pleased to present to the board today our refreshed communications and engagement strategy. This provides a framework for us in which we align our communications and engagement efforts to our broader strategic goals as an organisation, helping us to address our current challenges, but also looking at those opportunities for the future. A big thank you to the other Claire Routh, and the rest of the comms and engagement team for the work that they put into developing this, which actually utilises insight gathered from a range of our audiences to help inform the development of the strategy. It's designed to have a strong focus on responsiveness, inclusivity, and data-driven practices. So all of our insight and understanding of our audiences is ploughed back into the way we develop campaigns and communications programs going forward. The strategy is built around 3 core areas, so supporting the system-wide priorities, as I talked about, managing that business as usual comms. So a lot of our work is in the business as usual space, so keeping the show on the road, particularly with our primary care audiences, and making sure that they're aware of what's going on and actions they need to take as things develop operationally. It built on working with our internal, so our staff groups, and supporting that organisational development and cultural building that we're doing as an organisation. It talks about how we can prioritise and triage our work, recognising there are resource constraints within communications and engagement and across the wider organisation as well, to make sure that we prioritise the most urgent asks and requests to get the most bang for our buck, if you like, around how we're working with our communities and population. I think that was about it for me, Mike. Happy to take any questions, but ultimately it's an opportunity to set out how we want to be a transparent and accessible organisation.
Thank you. And this, of course, does take into account that the providers with whom we engage, they have their own, as it were, self-contained communications approaches and strategies and engagement with their communities of interest. And perhaps in retrospect, we might have had a sentence which just made that absolutely completely.
Yeah, absolutely. And actually our role in helping to make sure that we work together as a network of communications and engagement professionals.
Thank you. So any questions or comments about the strategy, which seem to me to be very, very clearly stated? Please go ahead, Mark.
Thank you. I suppose it's just a question of reassurance, because I think it is implicit in there. I'm just conscious around the need for engagement with particular groups, particularly people with learning disabilities, and the nature of the communication styles who have them, particularly since they form a significant part of the experience of health and equality, and multiple comorbidities that impact on there. And I know some of that's done through providers for the ICB. I'm conscious we refer to that particular provider as the Mental Health Trust and don't acknowledge those other elements. So I think it's just reassurance that when we talk about accessible information, we are going broader and targeted, just for people to be aware of.
Yeah, absolutely, Mark, and thank you for picking that point up. I think it's something us as a professional team are really conscious of, in making sure that our communications is accessible to a range of different audiences. And we've done quite a lot of work actually in the learning disabilities space in terms of that co-productive approach. A number of times we've developed materials in liaison with learning disability advocates and service users themselves. So it is something we are consciously aware of. But actually there's a good network across communications professionals in Essex for that. There's a group that Essex Health Watch help support us to. So if we've got materials that we're producing, we can go to them and get input into it from an early stage. So I think it's definitely a model that we're using in other areas as well.
Well, I mean, I think it's this is a good point, isn't it? Because as I remember, and please correct me if I'm wrong, but our take-up of things like health checks for people with learning disabilities is not where we would want it to be, for example. And actually, they're particularly vulnerable group, and early intervention will certainly help them, and it will also help us. So I think that might be worth a sort of takeaway from today's discussion to think about that.
Sorry. I'd like to come in. I couldn't have made it more obvious.
I mean, thank you for the subtle cue. Categorically not holding your ear. Joe, over to you.
I'll be quick after annoying everyone. I wanted to just say I thought it was a really, really good paper and a really good set of documents. I like particularly the candor that said we can't do everything, and that red, amber, green status, because I think that's kind of the mindset we're going to have to increasingly adopt. We can't do everything, and I really like where it gave clarity on responsibilities for communication and things of that nature. Really good guidance. So a really good paper. Yeah, thank you.
Thank you. So we're asked to approve this. Are we happy to approve? I think we are. Thank you very much indeed, and thanks to you, Claire, both Claires. You mentioned the other one in dispatches, and all those involved in putting it together. And we come on now then to emergency preparedness, resilience and response, EPRR core standards, and that's Emily.
Thanks, Mike, and thank you for taking on the acronyms. So I'm now going to just use the letters, if that's okay. But this report is to seek board endorsement of our EPRR approach and our annual core standard self-assessment, which hasn't changed since last year, and we remain at a substantial level of compliance. We've done our own undertaking of our core standards in our system, and then we've also had a validation conversation in the last week, actually just before the papers were published, with the region, who are supportive of our internal recommendation, just to give the board a little bit of assurance around some of the areas where we are only partially compliant and how we're working on those. One of the areas is around our capacity. We're focusing on joint working across the system. We've managed to fill a vacancy within the team, but we do continue to have a huge number of kind of EPRR incidents or reports that we need to work through. The team do that very well across the system. My screen is too small. Hang on. In terms of our duty to maintain plans, sorry, some of this is relying on external inputs around national guidance relating to pandemics and countermeasures, which are both expected in 25-26, and we'll be focusing on that. And throughout this year, the ICB has participated in a number of mass casualty exercises and is in the process of updating our own Essex mass casualty framework, which will respond to that. We're also working closely with colleagues across our whole supply chain, and particularly with those in primary care, around their own business continuity and how that links into our EPRR work. So grateful to colleagues who are helping with that. And then it doesn't contribute to our core standards, but you'll see that we've done a cybersecurity deep dive, and the EPRR team is working closely with Barry and his team on all the elements that have come out through that deep dive, and there are action plans developed in detail that sits behind all of this. All of that detail has been reviewed and approved by our audit committee, and again validated by our conversation with the NHS England region. So support from both of those groups of colleagues as well. So I'm hoping that the board will support our self-assessment and approve our rating.
And that's a cue for the chair of the audit committee, George.
Thank you. Yeah, it's there's a 120-page document that sits behind this, and we're fully compliant in 42 out of 47, and the team do a really good job in pulling this together. We review it every 2 months or 3 months at the audit committee, so very happy to endorse it.
Thank you. And Jeffrey was nodding, having read every single page as well. Good. So, I mean, it seems to me we've got the two external, as it were, slightly external, our audit committee and the regional team. Are we happy to approve? Thank you very much. And again, thank you, Emily, and everyone involved in putting it together. The anchor charter, I'm hoping this will be, for time management reasons, a relatively brief item, because we've signed this before. We've got a paper here. Is there any good reason why we wouldn't re-sign? Would be where I would be coming from.
No, I think I'm hoping this is a formality before we ask Tom to put his signature on this for us as an ICB. Hopefully you will have read in the paper the actions that we've already been taking in this space, and then what we're planning to do over the next year. Grateful to colleagues across all 5 pillars of the anchor charter who have confirmed how we're embedding this into our everyday business across the integrated care board, and it contributes to how we run as an organisation that's not just looking to deliver good healthcare outcomes, but also using the resources we have to best support the people of Mid and South Essex more broadly. And a number of our colleagues across the Integrated Care Partnership have also signed up, so thanks to those partners, and we'll be taking an update back to the ICP before the end of the financial year to confirm all of our partner signatures, hopefully including Tom's.
Okay, happy for us to sign. Yes, thank you very much indeed. We therefore move on now. Benchmark analysis of the Greater Manchester Review. This is Giles.
Thank you, Chair. And for the purposes of time management, I'll also include the quality report, which also covers additional aspects around mental health. So first to note, it was an action on the board for us to gain assurance around both EPUT and North East London NHS Foundation Trust's gap analysis report against the 11 recommendations made following the Edenfield Centre in Manchester report, which was subsequently reviewed by Oliver Stanley in January of this year. I can confirm that at the Quality Committee, and my thanks to Shahina and Quality Committee members who thoroughly reviewed the progress against the recommendations, noting EPUT's programme around the fundamentals of care and the Culture in Care programme that NHSE were running nationally, and also NELF's good work against those recommendations. The Quality Committee did endorse the progress and were satisfied in relation to that. So therefore that is the assurance through to the board. In relation to the quality report, the focus has been on further work in the mental health space, notably the Learning Disabilities, Autism and Mental Health Inpatient Quality Transformation Programme, and the quality report provides an update to the board in relation to the priorities that are focused in Mid and South Essex, which really looks at localising and realigning inpatient services, harnessing the potential of people and communities, and improving the culture of care and supporting staff within the organisations. There is further work which is underway across which is being led by the ICB mental health and LDA teams, focusing on purposeful admissions, therapeutic inpatient care and proactive discharge planning. There are clear commitments outlined in the 3-year plan to transform the quality and experience of care, and oversight by the ICB will be delivered through the Quality Committee. The other area of focus is following the sad deaths of Ian Coates, Grace O'Malley Kumar and Barnaby Webber in Nottingham, which followed a conviction in January of this year, which was an action for all ICBs to undertake a maturity index review against intensive and assertive outreach service models for mental health patients who present with psychosis. It is important to note that whilst these teams were in place some years ago, decisions had been made that they will be integrated into community mental health teams. An appendix has been provided to the board showing the progress and findings to date. I think it is positive for the board to note that there are examples of good relationships and joint working across organisations and agencies. These cover both health and social care services and criminal justice partners, substance use services and the VCFSE partners across Mid and South Essex. However, there are gaps in service provision which have been identified. There is a variation in service. The functions are dispersed across services and teams and across providers. Current caseload sizes are higher than indicated in the Dartmouth Assertive Community Treatment Scale, or DACTS, and community teams are not currently resourced to meet the level of intensity to be fully compliant with all of the standards. It is important to note that we are not an outlier in our system. This is something which is being recognised nationally. And there remains to be a focus on information sharing and risk formulation processes across agencies, better identification of people at risk and identifying non-engagement or relapse, and a better integration with housing, complex needs and substance misuse services. We do have a patient carer race equality framework already in place, and there is a call that we need to consider further work in that place. But with EPUT leading that in our system, it has been recognised positively. There are some resource implications, and of course we will continue to work with the regional and the national team following this review being completed. I'm happy to take any questions, Chair.
Thanks. So should we just split into 3 groups? So the Manchester update was really to make sure that we had thought carefully about the learning from there. So it's reassuring that we have engaged with that. And looking to see there's no questions or comments about that. And then next bit is around the Learning Disabilities, Autism and Mental Health Inpatient Programme. Mark, Rob, any did that? What were you reading that? You happy? Okay. Any other comments on that part of the quality report? And then last but not least, this what seems to me to be so difficult to implement, so difficult to be thoughtful and caring for people around this, so difficult. And so I'm very glad I haven't got the task of exercising judgment. Very, very difficult indeed. Any questions or comments about that? Joe?
Just one, Chair. It reminded me of an occasion when I tried 3 attempts to visit a service user when I was chair at NELFT, and how much energy you can put into somebody who just does not want to engage with you. It makes that degree of difficulty so high. The bar is so high. So I just applaud anyone who's working to close the gap, to be honest, because it's incredibly difficult. And I know from first hand trying to go with clinicians to engage. Yeah.
Okay, thank you very much. So I think on the quality report, we're asked to note it, which we do. Giles, thank you very much. And I know at some point you've got to leave us because you've got
Chair.
a conflicting meeting somewhere else.
Thank you.
Then we now come on to digital achievements. And this is a very cheering item. Barry.
Thank you, Chair. So this is the first report that we've provided to highlight progress that we've been made delivering on the digital and data strategy for our ICS, which has been in place for the last 2 years. In producing this, we were really keen to provide a view of what partners had achieved outside of that strategy within their own local organisation, and a point of thanks to all of your teams that have provided the content that helps share the reports and information today. I think it's worth highlighting that to deliver on these programmes, it's required considerable discretionary effort and perseverance from all of the partners. It's not hard, it's not easy to deliver on some of these change programs. So I hope you'll join me in kind of recognising the inputs from each of your teams in achieving that. The report that you see today went to the Digital Data and Technology Board for the system earlier on this morning. It was supported and endorsed fully. There was a clear recognition in the conversation that actually the report doesn't reflect the whole of the achievements, and primary care was a focused conversation where more had been achieved in that space than what's actually covered within this report so far. It was also supported at DDAT to suggest that we look at doing an annual report moving forward, which was fully endorsed by all partners around the table this morning, and helps give traction and evidence in terms of the impact we're starting to have. So it's here, there's 3 recommendations in there around recognising the content of the paper that you've got in front of you. It's the first time we've done this, so if there are comments or considerations, and maybe due to time, happy to take those offline about how we could improve that moving forward, then more than happy to take that on board. And what we're keen to do is support the promotion of this again with our national and regional teams, but also to ask that as members of the board, you work within your own organisations to support the recognition of the achievements that your teams have made over the last 2 years. So, Chair, thank you.
Thank you, and thank you, Barry, for leading this work. I mean, we several years ago, we were coming from behind in this agenda, and we now find ourselves at the front. So thank you and everybody. As you say, it will be an army of people behind all of this, and actually, the outcome will be as good as your combined ability to engage with the community that we need to have use this. And so for me, it was good to see some of the activity and plans for activity to make sure that people do use it, because we don't want something sitting in a box, a nice, glowing, colourful box that we've paid a lot of money for, and then it doesn't get used. So that's a crucial part of the pudding, isn't it? And some of it in the next stage. So thank you all. Comments, questions, please. Yes, please, George.
Barry, one of the things that we talked about, I think the EPR programme when MSE and EPUT, was the benefits that are going to flow out of the new system, and the opportunity to possibly bring some forward, because some of them weren't all digitally related. And I guess the challenge for me with this in any NHS organisation is taking cost out. We're good at putting it in, but not good at taking it out. So it'd be helpful at some point in the future to get a list of the things that we've mechanised, and yet we haven't seen a reduction in operating cost or people coming out for our providers, please.
Yeah, so thank you, George. And that's a particular area of focus. We've got our CFO within Provide who runs the efficiency element of that program. And what we're specifically asking is, now we've got the implementation for the shared cared record, which went live at the end of August, how can we work with you and your finance teams to take those items out of the bottom line? So we're trying to encourage that conversation more. What we do need is all partner organisations to own that within their own organisation to drive those kind of costs and efficiencies out. One thing to say, so in the paper it calls out £1.7 million, I think, worth of savings. That's gone up to around 2.1 so far from further work. But what we do need is that bottom line takeout. Agree.
Matt?
Thanks, Barry. From a clinical point of view, we can digitalize stuff, but it's not always helpful to clinicians until it joins up and makes productivity better. And we know that from the Darcy report, etc. But I just wanted to use a really practical example in our system. For example, over the last few years, we've developed a system-wide dashboard for several metrics, but particularly for, say, aging well. So we can see outcomes for our older population across the system. We've developed registers where we can identify individuals, and we've developed an evidence-based tool where we can code and identify how many of those individuals have had the evidence-based intervention. So it's a brilliant example under Barry's leadership where these things are joining up and where they can make a difference in practice. And then someone can ring me on the phone and I can see all of that information on System 1, which is our provider that we use most of the time around our system. So an example of joined up data sets and using population health for improving outcomes for our patients. So I just wanted to give it some clinical context because it does make a difference to me practically, and even more so as we get more unified records in the next couple of years.
It's certainly been mentioned to me, for example, that sometimes when it's paper-based records, those records might need to be moved between one of our hospitals and another as a patient shifts hospital for care under modern thinking, so that's the most appropriate place. And then what are you going to do with paper records? Well, they're either going to have to be posted or carried by an individual across, aren't they? And online is the obvious answer to dealing with that. And then there will be all sorts of savings if, for example, for any reason, the notes don't get shifted across. Neha.
Yeah, thank you, Mike. Barry, of course, this is brilliant, and we should put as much focus on this to make it a success going forward. Now, you mentioned in terms of data linkages and so on, that the uptake of it, we've discussed this. In all of this implementation of it, the weakest link is the problem where you don't know whether people, which are the people who are not using it and what are the data that's not being linked into it. So while we have data on how it's being used by those who are engaged, how are we dealing with those who probably are not? I mean, what is the engagement strategy to build up that engagement?
Thank you. I mean, that's a great question. So literally this morning, we were focusing on that point with MSCFT, who are, for example, the biggest users on the shared care record. Out of the 4,000 people using that, 3,000 of those come from MSCFT. What we are asking for is an unpacking of understanding the type of staff that are using it, understanding which services they're working with, and being able to use that to basically work through, one, what's working really well, what's not working well, but also to highlight where other services aren't using it so we can start to have that proactive conversation with them. So MSCFT was the first case of example. We'll look to have similar conversations again with other partners. One really quick point. So Thurrock, we know, have gone live with the shared care records. So thank you to Mandy and Sean in your team specifically on there. There is an open conversation across with partners where actually utilisation is a joint conversation. So Essex County Council have had access to a shared care record before, and they're engaging in that proactive conversation together between themselves about how they drive utilisation, which again just shows the culture of partnership working, which I think is great.
Thank you. The two of you, I don't know who was first, but Jeffrey and Shahina.
Yeah, I think I've asked this question before, Chair, but I've read something here that says the shared care record will join up care across health and primary care networks as well. So because I think the example, I was speaking to someone, hopefully, thankfully in another ICP, whereby they because of the diabetes that was poorly controlled, they ended up in hospital, life support, the kidney failing, everything failing. They were there for nearly 3 weeks. They came back, but the GP was not aware of all of this. So when I don't know how exceptional this is. So when he then reported to the GP for some help, the GP, the first thing is, how can I help you? So he was kind of taken back, having to tell that story again, including the medication that he doesn't know of. So I wonder to what extent, because, this break between the GPs and primary care and all of this fantastic work, are we going to be breaching that or, supporting that or not? Because that's what I read here.
So both Barry and Anna might like to comment on that.
So short answer is yes, Jeffrey. What I'm happy to do is show you the roadmap of extension of use for the shared care record. So we've gone live, but there's a continual roadmap of implementation using Agile. But yes, it will is the short answer.
I don't have a lot to add really, Jeffrey. I don't think we're really using shared care record fully in primary care yet, because we tend to sit in system 1 most of the time. So I think there's work to be done there.
Thank you. Shahina.
Barry, this is really good. In terms of management of certain conditions, you would need other sort of data, images, for example. And have you come across any barriers in importing any of the images into the shared care? Because that's really, really quite important for cancer ophthalmology, for example.
My button wasn't working, sorry. No, not yet. So we've got three kind of approaches in terms of development. So one is reaching as many partners as possible. So bringing it on for a breadth of integration. Depth is the other side. Images, so radiology, pathology, diagnostic information, etc., is on the roadmap for implementation. And actually, in October, we just saw emergency discharge information from MSCFT added. So we've got a roadmap which continues on that development path. No issues so far in terms of the sharing of the diagnostic information.
May I encourage you to look at ophthalmology as well?
I knew that was coming.
And actually maternity for that reason, in terms of imaging and so on, and ultrasounds too.
You've got two supporters and champions there. And on the primary care, I mean, I'm sure there must be things missing, because I was sharing with somebody the other day, our remarkable GP, and for what I know, there might be several of them now involved in total GP triage, and that couldn't be done without underpinning of IT setup, could it? You see, so there's more to this than meets the eye here, I would say, and things again that we should be equally proud of, because the person I was speaking to seemed to be unaware of another bit of leading edge practice in our system. So we note the update, and again, congratulations, Barry. Please pass on to all the teams involved in making this happen. We now come on to the Chief Executive's report. Tom.
Thank you, Mike. So I think probably obviously I'll take the paper as read. I think just to draw the board's attention, I think probably to the areas of major concern. So not to be a downer after Barry's item, but I think it's important that we're quite clear-eyed about that. So obviously, as we've already discussed, the risk around winter is significant and one which is going to require very active management. But in terms of the other two immediate term issues and challenges that we face as a system, which actually we'll probably say in a moment, the financial position that the system finds itself in is not good, and although there is early indication of some of the intervention actions that have been taking place that there's been some improvement, I don't think we can say that we're yet confident that we are going to be able to get back to plan. So there's significant challenge and a significant push that we're going to need to work on across the NHS in order to to successfully deliver our planned finance position. And then the second area of kind of significant concern is in regard to cancer performance. And so we know that the access standards in Mid and South Essex are amongst the worst in the country. We know that the fast diagnostic standard, although there has been some improvement, is not as good as it needs to be. And we also know that our outcome measures from cancer are not good either. So a range of action is being taken on that. Myself and Matthew met with our respective teams on the 28th of October to look at that. I think that we have got some assurance through that in terms of areas such as skin and colorectal services, but we know that there are some other areas that require some additional focus in terms of making sure that we've got the right capacity in place, that we're doing everything we can to streamline our existing processes and pathways so patients get their diagnosis as fast as they should and they get the treatment faster than they currently are. And so it does need to be an area I think we will need to keep very close eye on as a board, given the level of risk, I think. And equally, we know that we can and we should be doing better for patients in terms of cancer treatment. So I just wanted to kind of highlight that, Mike, say that I don't think we can yet be fully assured that the actions that are being taken are sufficient, but it is something we are working on and something we may wish to come back and have a slightly longer session on at a future board meeting.
George wants to come in.
Yeah, if you don't mind, Tom, I'm sorry that Matthew's here not to take my question, but we seem to be unable to show continued improvement on cancer. We're running at 50, just over 50% on referred to treatment, and we've committed to get to 70% by March 25, and we're already behind plan by about 7 percentage points. I struggle to see how we're going to make this leap from 50 to 70 over a winter period. The hard work should have been put in place. And obviously there's a big patient outcome here in terms of sicker patients are not getting seen appropriately. So I think whether it's a note to Matthew or whatever, but I think I'm very concerned about the performance because I don't see anything on the data that shows that we're going to get anywhere close to 70%. I struggle to see we'll get above 55 to 60. Sorry. So I think it needs to be elevated. It would be my suggestion, please.
Yes, Joe.
Just a supporting observation, Chair. I noticed in the letter that came to us after the review of region, it was the very first bullet point on the regional directors list. So the fact it's not moving anywhere in a positive sense won't be tolerated, I don't sense, for very long. So we need a plan that's going to show we can move the needle.
And one of my frustrations is that actually sometimes we've as it were had a friendly word and pushed to get things moving, and they've improved, and then the minute we've stopped, as it were, the friendly word, it's gone back again. And I think now is the time for us to say that we need to work together, please, to get the level of ownership of sorting this out that we need to on behalf of the people we're here to serve. That would be my view. We've shown we have the ability to do it, but it shouldn't just be for a certain period of time. We need there to be continuous improvement. Perhaps the analysis is wrong, but that's what I've witnessed in the numbers coming across here.
Yeah, and so I think if you're happy, Chair, maybe we can take an action offline to craft that communication and have that conversation.
And maybe the suggestion of a kind of deeper dive into this would be, I think, the right approach, because we need to get better at this. Other aspects of Tom's report we're coming to finances shortly on the agenda, and that remains an area of anxiety. But other aspects, Okay, thank you. And thank you, Tom, for all the hard work that you're putting in. Much appreciated. So I'm going to move on then. Thank you very much. We've done quality report to finance and performance report. Ashley, that's you.
Yeah, thank you, Chair. And it's okay with yourself. I'll take the finance part first and then pause for questions, then pick up the performance part after that. I'll obviously take the paper. I need to get really close. Okay. I'll take the paper as read. The position is as reported to the Finance and Performance Committee on the 5th of November. I'll pull some key points out though. So in month 6, the system received its deficit allocation funding of £96 million. This is to make sure that cash is in the right place for systems to effectively discharge their duties. What that does, it adjusts the deficit plan to a break-even plan that is presentational. So it is a deficit plan, and the deficit will require repayment in future years. In regards to year-to-date position, the ICB and the system as a whole remains off plan at month 6 with a combined deficit position of 28.6 million. It's a reflection of the ongoing cost pressures. There are no new deficit themes to date. So consistent with previously reported information, including slow efficiency release and pay and non-pay pressures across workforce and drugs and other non-pay areas. The system does, however, continue to forecast delivery of its plan. There is a route identified to deliver the control total, although it is very challenging and requires a steep improvement from month 8. We are hoping to see some movement in month 7, but numbers are currently being finalised. Obviously, this is all in the context of winter that we discussed earlier. Finally, I just want to pick up in regards to capital. There are currently no concerns. There was a discussion at Finance Performance Committee last week in regards to understanding capital requirements for the future years, and that will be picked up through committee. So if I pause there, I haven't moved, do they? If I pause there, Chair, and take questions.
Thank you. Joe.
Just wanted to comment on the 28.6 against Ashley's report in the context that I guess that means we're, worst case scenario, we're looking at 125 million total deficit. I think it's worth pointing that out to colleagues as a number. The other thing is that we've got reported to us very high expectations of what I've often called the inflection point happening somewhere between month 7 and month 8, which is where we turn a corner. And at the moment, I would say assurance and confidence is pretty low. So it might be useful, it's a suggestion, happy to be shot down on it, but it might be useful to understand a better sense of best case, worst case, because the forecasting is increasingly, from people I talk to, feeling unrealistic. And I'll leave it there. Thank you.
And I guess, Joe, the point behind your question, this inflection point is if we go into the next financial year, not having got the house in order, it will be even worse, not least of which because we've got to pay some of the 94 million pounds back, etc., and all of that. So, Ashley?
I think that's a fair challenge, and you can straight line it, and it does give that large number. As I said earlier, there is a plan, and it is incredibly challenging. We are reliant on that inflection point being hit in month 8, so we are working closely with providers to understand the realistic nature of the plans that have been submitted and looking at revised profiles being provided.
Yeah, and I think on the second point, I think there probably is something, I know we're working on it through Finance Performance Committee, aren't we, Joe, in terms of the, and I know it's a point George has made recently to us, is the in-month run rate, and just be pulling that out very specifically, because I think that will be helpful in terms of understanding what the exit from 24-25 is, and therefore what the entry rate of to 25-26 is. So we understand what is the scale of the challenge we're potentially building up moving into the new financial year.
Correct.
George?
Thanks, Mike. Ashley, have we got to submit, when is our budget due first cut for 25-26?
Dates haven't been published as yet. We'll be starting our internal plan in December.
So we'll be getting to that month, 12th month quite soon in terms of understanding what that number looks like.
We will, and we'll be starting now in terms of
Okay.
understanding the underlying position.
So either at the next board or January's board, we should be sated
should
on.
have an idea in terms of those numbers that you've asked for. Yeah.
Thanks.
So could we just rehearse, please, we've got, there's three components to this budget overrun. There is us, the ICB, ourselves, and could we just rehearse, please, what we're doing to deal with that? There is our hospital, which is the major driver of the deficit, and we should just again rehearse what new has happened. And there is plenty since we last met that's trying to deal with that. And then also to talk about our major mental health provider, where there is also a budget overrun, which is also quite a challenging proportion of its turnover. So could we just please rehearse what's happening about each of those three components?
I can pick that up, Chair, and Ashley and Joe might also want to chip in a little bit. So in terms of the ICB position, that is principally driven by all age continuing care. And it is a combination of both demand increases that we're seeing alongside kind of increased kind of per patient cost, I guess, in terms of package costs of care. In terms of the action that we're taking is we are specifically focusing on the operation of the discharge to assess pathway, because we know that currently that pathway is delivering very poor outcomes for patients, yet also being very expensive at the same time. We are implementing a trial or pilot of a new model from Monday, which will look at concentrating discharge to assess patients in a smaller number of homes and a repurposing of our some of our rehabilitation services to wrap around those patients alongside a CHC case manager. The aim of that is kind of multi in terms of, so firstly, in terms of being able to make sure that we're getting the best possible prices in terms of the package of care we provide. Secondly, making sure that patients are getting the necessary therapy and inputs to help re-able them, which should reduce length of stay and hopefully get more patients home successfully, as opposed to staying in residential or nursing home care indefinitely. The other thing that we're currently working on, and hopefully going to be doing a pilot initially with Southend, is joining up our brokerage functions between all age continuing care and local authority partners, because we recognise that some of our purchasing activity isn't helpful more generally within the system, in that we're bidding up the market. So being able to join up our brokerage function, I think, would be a fantastic opportunity, whilst we do some probably longer term partnership work around discharge pathways more holistically. If we take, maybe I could take EPUT next in terms of mental health services, Mike, and then we can talk about the hospital. So the major factor with EPUT is the costs of temporary staffing associated with the new model of care that is in the process of being implemented alongside, and so obviously EPUT have been recruiting into, and actually some of the work that Kathy's led, I think, has been very good in terms of bringing in healthcare assistants, but there's still a gap in terms of being able to fully implement that model, and therefore there are some premium costs associated with that. We are and continue to have a conversation with EPUT around the profiling of that spend, and so when that will drop out, and therefore we'll start to see an improvement. The secondary issue that we have within mental health services is a significant increase in the number of out of area placements that are being made for patients in Mid and South Essex. So they're around 100, I think, is the current number. And that has partly been driven through demand, but also an increase in length of stay in mental health inpatient accommodation. Now, there's an element of that which there's a kind of a belief as a result of some of the things that have been going on. There's an increased risk aversion in terms of people making discharge decisions, which, you know, is a very human and understandable thing. We have recently worked with EPUT to undertake MAID event, and so that's a multi-agency discharge event as described, to look at patients who are currently sitting within the EPUT bed base and to understand what are the blockages. There are some blockages where we need to look at working with partners, and so around accommodation and housing and issues like that. However, there's also a lot that can be done internally in terms of the internal systems and processes within the trust as well. And so we are just waiting on for the action plan on that work to come through. EPA have expressed a confidence that they will be able to get back on to plan. In terms of MSEFT and hospital services, and so there's issues in terms of both pay and non-pay spend within the hospital trust, and so there's been a whole series of actions that have been taken really in the last 3 months or so. So we supported alongside NHS England to put in place a turnaround director and a turnaround team within Mid and South Essex, which is been implemented and in place now. There's been a lot of work around agreeing rosters and the implementation of those rosters, and so we can make sure that people, wards and clinical areas are safely staffed but not excessively staffed, and there's an appropriate use of temporary staff where that's needed, and that's what we should start to see in month 8 particularly. So that's currently going on. They have made some decisions around the reduction in bank rates and in rates both for doctors as well as other clinical staff. That is in the process of being implemented, and a number of other changes in terms of reduction in kind of non-clinical, non-patient facing time. So some trimming of things like induction periods, holiday. People were granted an additional day off for their birthday. That has now ended. So a series of actions like that. On non-pay, we had a proposal through to our approval processes on Tuesday to look at putting in additional capacity within the procurement team. They're carrying a number of vacancies within the Mid and South West procurement team, and so the aim of that will be to make sure that we're taking advantage of national procurement frameworks, we're standardising across the 3 sites where it needs to be standardised, and really driving forward in terms of some of the things where we know we can buy the same thing, but we can buy it at significantly lower cost. So that's the sort of the non-pay element. Joe, is there anything, or Ashley, which I've missed in terms of some of the big items? Rostering, yeah. So that was the rotors. Okay. Mike, yeah.
No, I don't think there's anything specific, Tom. I think your point being we should see some improvement in month 7. We're really looking at month 8 to be the bigger improvement and to be sustainable. But winter is a risk, as is our performance in terms of RTT and cancer, where we may need to have some insourcing or further outsourcing, which potentially generates further risk.
Yeah, so I mean, we continue to work in partnership. The hospital has the advantage of this nationally funded turnaround team to help move things on, and I think they have made a big difference in the 2 months that they have been there. We hope this will be sustainable change there, but it's rather late in the day, which is your point, Joe, for us to be at this time, I would say, confident that we will go into the new financial year in a position of sustainability or getting to sustainability. So we just have to keep an eye on things and work as ever in partnership to try and get us all to a better place. That's what we're here to do. So that's for finance performance.
So for performance, obviously the report presents a number of constitutional standards, and work does continue with the Finance Performance Committee about how we refine performance reporting moving forward. The report obviously identifies that for urgent and emergency care, performance continues to be below the standard required for ambulance response times and ED waiting times. A number of actions are in place, and they were identified and discussed earlier under the winter plan. Elective care performance also remains below the targeted national standard for diagnostics, cancer waiting times, and referral to treatment times. And again, Tom's mentioned the actions within the cancer arena as part of his update. Referral to treatment times work is underway with the national team supporting on reviewing additional activity and trajectories. So that is in train. And for mental health standards for improving access to psychological therapies and early intervention in psychosis, as at August, targets are being sustainably met. So again, I'm happy to take any questions, but I think we covered off some of the actions earlier in the meeting.
Joe?
Mine's just a technical point on terminology, Chair. I noticed on the ambulance response times, it says we're above the respective standard. I think if it said we're not meeting it, it might be, because on the graph, it does look above, but above is not meeting it. And other ones, we say we're below, and that means we're meeting it. So at first read, it can be quite confusing. If we standardise the technology into whether we're meeting, not meeting the standard, it would be more consistently understood, perhaps.
Yeah, I'll feed that back.
This is British summertime and winter time again, isn't it? Indeed, yes. Clarity will help us because we need to be just quite clear about where we are and work cheerfully together to get things to a better place as quickly as possible. I mean, on that note, I'm just thinking back, having talked about the national team having helped us on the area of finance, we have had national support for cancer before, haven't we? Actually, on more than one occasion. And it's not been clear to me whether that has made a difference or a permanent difference. And that may be just memory, so I can't remember that. But you'd think if it had made a big difference, it might have stuck. Tom?
Yes. So I think that's part of the challenge that we have, is that there's clearly a bit of a Hawthorne effect in terms of, so we find someone and we put somebody on a specific issue and we do see improvement, but then what happens is that resource or support moves away and the performance slips back again. So there's a real challenge around sustainability. And so what I think we need to get to is a good structured transformation program for cancer that really kind of sets out both the immediate term actions, which will be tactical and operational in nature to improve performance, but actually those longer term pathway changes which will underpin a much more reliable cancer service for the people of Mid and South Essex. And so how do we change the diagnostic pathways? How do we need to change the way that currently clinical capacity is configured within services? And indeed, there may be some areas where we say, actually, the nature of a particular service is such that we need to look at how we work with other systems and partners in order to make sure we have the critical mass in some of these kind of much more specialist areas. Specialized is a different thing. Specialist areas to make sure that we have a really properly resilient service, because we don't want to be in a place where we're reliant on, a service which only has a couple of consultants and therefore annual leave, Christmas, bank holidays and things like that have a disproportionate effect in terms of our ability to deliver a sustainable service. So I think that's what we should be asking for, Mike, and we alongside the hospital will kind of need to work on that plan to give this board assurance.
Thank you. Anna?
Tom, I guess that's why the head and neck figures are quite so bad, because it's a very specialist service with few consultants running it, and that's why.
Yeah, so
because it stands out as being.
So I think
worse.
head and neck is a service that falls into one which we need to take a proper look at in terms of, is it sustainable in its current form, or do we need to look at networking in? We also know that we have some particular quality challenges in terms of access to restorative dentistry and things like that. So I've already started some conversations regionally about looking at a potentially different, more networked model of care for head and neck, and so people can have a service they can rely on.
Any other comments or questions on performance? If not, I'm going to move us on to primary care report.
Thank you, Mr. Chairman. And I will open the paper, but I'll ask my Alliance colleagues and Anna as our GP representative to make comment as well. So I will take the paper as read, but most notably since we last met, and I think it talks to Barry's item that he's had on here, we've had a significant rollout of increased digital tools into primary care that do support that total triage approach. But this is all done in concert with the current collective action that, of course, you'll be aware of from media coverage around the GP's position on their increased activity that they are seeing in their daily workload. And from the narrative that we've established with the GPs on that matter, you will see in the paper that there's been some areas of development around our prescribing pathways, particularly for ADHD, and we have made an offer to our GP colleagues around the support of that vulnerable group, and also pathways, other prescribing pathways with community colleagues as well as the acute hospital. We've also, in the dentistry space, delivered some great outcomes from our care home pilots, and we'll be talking about that again in further sessions, and unlocked some of the Section 106 money that has been held with local authorities to enable us to do some redesign and development work with estates in general practice. There is another integrated neighbourhood team that has gone live since we last met. So we have one left to go. It is one of mine, so I can sit here and say that confidently that it will be delivered. And we continue to work with colleagues from the local authority around the Better Care Fund. But I think my colleague Becky Jarvis would like to make comment on that around the additional work that's not covered in the paper. But I'm happy to take any questions on the content of the paper, but significant work continues to be undertaken.
And indeed, there is a list here of that. Thank you. Becky?
I won't say too much in terms of time, but I think, Mike, you made the reference earlier that what underpins a lot of our system of financial priorities is around partnership and system working. And actually, we at an alliance level have really started to think about how do we build those relationships with our managing directors from the hospital trust, but also obviously continue the partnerships we have with our local authorities and wider system and community partners to really think about how do we accelerate delivery of some of this, whether it's virtual wards, whether it's the relationship with primary care and secondary care around what we said earlier around ESTEC. And in addition to that, using the levers that we have in our disposal to do so. And the Better Care Fund and our discharge monies is one of those examples. So actually, there's a huge amount within that investment looking at how we accelerate discharge, support people back to their usual place of residence. And that's the work that we, obviously, as Alliance directors, keep hold of.
Thank you.
And Anna, we've got the exciting emergence of our GP provider collaborative that is working frequently and hard together to start to look at that how to hospital model in a new way and support general practice in its sustainability, and really talk to the Darcy report around that left shift. So how can we do things earlier in people's pathways as opposed to be reactionary? So it'd be great for a little bit of commentary on that. Thank you, Anna.
Yeah, sure. So the GP Provider Collaborative is developing. So we are meeting monthly at a system level. The individual alliances have their own subgroups who also meet monthly, and we have a governance working group meeting fortnightly now with a bit of external support to try and get the structure of the GP Provider Collaborative developed and some terms of reference and so on. So it's proving to be quite hard work, obviously, because you're bringing together 140 odd disparate practices, but everybody is still very firmly of the opinion that it's the right thing to do. And we've seen some really encouraging progress in terms of the engagement of the GPs, and also just sort of tackling some of the hot topics that are coming across our desks. So yes, it's it's good work. It's definitely worth doing. It always takes longer than you think it's going to take. We're working closely with the LMC on this, so that is a very positive step for our system, and I hope it will help us with our relationships across general practice and then also with our secondary care colleagues, because some of the things that the GP Provider Collaborative can really support with are around the interface working both with secondary care and with our community colleagues. So yeah, it's going well. Thank you, Pam.
We hear the underlying pain in giving birth to this this initiative, and we're very grateful indeed for that. Further questions or comments on the primary care report? It will be cause of celebration when we get that final team in place, won't it?
We are working on a dashboard, performance dashboard, and we hope to have that with you in the next paper. We're working with Barry's team on that alliance level data, so you will receive more data for the sort of areas of primary care performance that link into alliance relationship development. So,
thank you, Jeffrey.
Yeah, just a quick question, really. At the alliance level, what's the level of, just at a very high level, what's the level of participation and engagement with the VCS in all of what we are doing at the alliance level, whether that's integrated level teams or just to get a temperature of that? Thank you.
I think that there is good level of engagement. So across now emerging all of the alliances, I say that, I think it is all. We are chaired by a VCSE provider, or there are plans in place to be. So that's positive. We've got strong networks. I do think, as someone that's an advocate for the voluntary and community sector, the work that we do, we always need to hold the mirror up to us and say, is there more we can do? Is there more we can do to think differently about our models of care and the role of the VCSE? The acronym's really difficult, isn't it? The voluntary, community, faith, social enterprise sector can play into supporting that. So I think that's part of an ongoing process. And then equally, the work that we're doing with our ICP and community assembly continues to develop.
And this is back to what I was saying to Rob earlier about us finding alternative ways to build into our thinking the agencies that we feel strongly can help us, respecting the legal framework that we've been given around this table.
I think it's just worth saying that we have had an internal audit on our alliances, and it's gone to audit committee. We're working through a targeted response to that, but some of that has just been addressed by Becky around independent chairmanship and also, you know, some of the governance around us. But it was a relatively good rating with some actions to come out. So we'll make sure that that's shared with the board once our action plan is completed. And it is Basildon that remains to establish its independent chair, but I do have a plan. We are newer than any of the other alliances, so we needed to establish a position for a chair to work with us on, and we've matured to that now. I think this is a fine example of a VCC working. Actually, the classes that you've seen there were run by charitable organisations and CIC, you know, with support with carers groups, etc. And it's very vibrant when you start to get down to you know, hyper-local spaces, and we'd invite any of our non-executive colleagues to come out and see and feel what that looks like in our alliances. So please do come.
Last comment, Jeffrey, because then I need to move us on.
Yes,
and Simon under the wire, and then that's it. Okay.
Yeah, I just want to explain why I asked that, because the chair, Mike, has asked me to lead a conversation with our VCS FE partners, and Emily and Claire will be having this conversation over the next 2 to 3 weeks. Thank you.
Thank you. Simon.
So it's not explicit in the paper, but just to say that our Essex County Council social work teams are very closely aligned to neighbourhood teams as well. So we work with MDTs. It's just important to add that. So there's a lot of really good work on in that space.
It's good to hear. Thank you. And thanks to your colleagues who have been helping with that. So thank you very much. Progress continues in and around primary care and the alliances is much appreciated, as indeed is all the hard work that goes into us moving this ICB forwards. Thanks to you, Tom, and all of your colleagues for the hard work. And in passing, before I forget, to those colleagues who put the papers for these meetings together and organise them and keep me on track, because sometimes I just forget that that's all happened, but I appreciate it. We come now to items of governance, and because all of these things are likely to have been to other boards and committees elsewhere, I go through them quickly, but please speak up if anybody has any concerns. We need to approve change to the ICB constitution required nationally to have a senior independent director, what's informally called a SID. This incorporates a SID into the things. That's a requirement, and the documentation does that. Everyone happy with that? You have to say yes, because otherwise we'll be in default. But I think we've done it. We've done it minimally to distort our previous ways of doing things there. The Board of Assurance framework is there for noting. That's looked at by our various subcommittees. We've got updated terms of reference for our People Board, the Digital Data and Technology Board, which is kind of been there informally, but now it's now putting it on a formal basis. And we have the scheme of reservation and delegation, which has been changed to reflect minor structural changes and also one or two minor financial limits. We haven't given suddenly someone who previously was authorised up to £1,000 now, £10 million, if you see what I mean. These are just minor changes. I'm going to go for a full house, if you see what I mean. We've got new and revised policies. There are a whole series of them to note. These are human resources and other policies. We've got the approved committee meetings, committee minutes from various committee meetings. And then we've got these urgent decisions where I will just pause for a moment, where we've previously as a board agreed that purchases should be made, and we have now done that. So are you happy to approve and or ratify where it says that? I'm assuming, as ever, that people have read the papers. All approved and ratified. Looking at Nicola, am I okay? Good, yes, pass. Good, thank you very much indeed. So now, I thank you, members of the board. I thank members of the public. This is a meeting in public, not a public meeting. We now have part 2 of the meeting where we have to discuss commercial matters, which have to be done in private. So we say thank you very much for being with us, whether you're here in person or online. There'll just be a few minutes pause so that we can then move on to the new bit of the agenda. Just